for other people. All right. Yes. Okay. Thank you. So let's try to get over the binary. It can be a problem for many individuals because, again, as we understand, the binary is limited. It does not encapsulate or encompass the very, very vast spectrum of gender identities and affectional orientation. So we have to be mindful of those that we address may come into our office and along these lines of some more non-binary entities, feminine of center, gender fluid, as some people have commented before, gender non-conforming, gender variant, masculine of center, queer, and two-spirited, as you all have commented in the chat box as well.
Okay, so let's talk about privilege. When we're talking about all sorts of multicultural issues, there is privilege involved. And as we're talking here about affectional orientation and gender, this little meme, I have the privilege of being totally unaware of my privilege, is often applies to lots of people who don't know that much about affectional orientation or the experiences of people who identify as gender nonconforming or whatever their gender identity. So can you think of some straight privileges? We'll kind of go through them. Can you think of any privileges that come to mind?
Heteronormative behavior, assumed heterosexuality.
Right, right. So if you're acting a certain way, you must be straight. Yes.
Or heterosexuality being the default sexual identity.
Yes.
Or sexual orientation.
Exactly. Thank you. Straight being the norm. Yes, PDA is totally fine if you're straight, but then people look down upon it if it's anything other than that. Not having to explain your romantic life. Yeah, PDA. Right. There's no need to come out if you're straight. Nobody makes you do that. You know, lots of privileges with having a marriage ceremony or going places in public, explaining your spouse, etc. I think you're on the right track here. So cisgender, meaning that you identify with the gender that was assigned to you at birth. What are some privileges of being cisgender? Bathroom use, for sure. Mm-hmm.
Just the idea of being more acceptable. Even in the queer community, you see like cisgender expression is more acceptable than transgender and men who present as feminine and women who present as traditionally masculine. And so this is to be marginalized on both fronts. So those are some privileges of being cisgender.
Yes, thank you for adding that. And as we go throughout the presentation, we're going to talk a little bit about, as a community, the LGBTQ community has groups that are looked down upon, treated unfairly. And so that is kind of one example. Will you be safe in the bathroom? Will you be accepted socially? Exactly, thank you. What are some privileges that people experience in schools or in agencies when you're thinking about your counseling work? Yes, safety and acceptance. Thank you so much.
I have the privilege of not having to tell someone my preferred pronouns.
Yes, right, exactly. And even in such an accepting program like I have here at the Chicago School, and I'm sure you guys do in your other counseling programs, it still makes that person come out even more. And that is a privilege if you don't have to do that. Okay, thank you so much. We're gonna move along here. This is obviously not every pronoun that exists, but I always like to show this. It's from the University of Wisconsin LGBTQ Center. These are some pronouns that some people prefer. And I think even my 7-year-old knows he, she, and they, and then that's it. And so a lot of people are good with, okay, you might be he, him, his, she, her, hers, and the they and theirs pronouns, but you don't realize that there are others. And these are not all. I've had clients in the past who I say, what are your pronouns? And they they tell me and I say, oh, great, thank you so much. I actually haven't heard of that. And I had one client who said, yeah, I just made it up with my friend. And so that's what worked for that person. And so of course we respect it and go with it. But here is a list of pronouns. We want to be super aware of our heteronormative and gendered language in our work. And I'm sure that as we go through this, you're thinking about where you work or places you've worked, and if you had this language or not. But these are some suggestions. To remember that not everyone is straight, not everyone is cisgender, even when they're very, very young. So I have a 7-year-old who is very fluid in their gender, and some days likes to present one way and some days another, and this person is 7. So the idea that kids don't have any idea what's going on is not true. Kids don't understand these complicated terms. I think kids understand stuff better than adults. You tell a child, this is this person's pronouns, they say, okay, you know, most of the time. So it's something that we can start using in our practices without worrying that kids will be too confused. We don't want to misgender people. Misgender is a term where we fail to use or even acknowledge the person's pronouns. We want to just ask them, what are your pronouns, and not say, what do you prefer? Because that makes it sound like, we kind of go between. You just say, what are your pronouns? And the person will tell you. But we definitely don't want to call like things like ma'am, sir, guy, girl, etc. There's not really any need to do that. We can just ask them. It's very anxiety provoking for people who, and I think somebody jumped in and said that, having to kind of out yourself with your pronouns is very anxiety provoking, and getting the pronouns wrong is very stressful for individuals. So we're gonna just talk about a few identities and a few statistics.
Are you gonna ask me something about an outfit, or were you flirting?
That? Okay, so here's some stats. Now, GLSEN has a school climate survey. It's updated regularly. These stats are from the 2017 climate survey. And basically, the reason these are important is because if it's happening in schools, it for sure is happening for our clients as adults, as college students, as grad students, etc. Nearly 60% of students that are LGBTQ plus in that kind of umbrella felt unsafe at school because of their sexual orientation, because of their gender expression, or their perceived sexual orientation or their perceived gender. So meaning they might identify as a straight person, but if their classmates think they might be gay, they might be getting bullied. So that I think is really important to note. Safety is a primary concern for these young people in bathrooms, as you noted, locker rooms, and like gym, physical education, those kind of spaces. Many are avoiding school functions and extracurricular activities because they feel unsafe and uncomfortable. I know this is a lot of stuff, so I'll just kind of highlight here for you, but almost 30% were physically harassed at school, so they're pushed, shoved, that kind of thing. Again, because of their sexual orientation and their gender. 12% were physically assaulted at school. 48%, almost 49% have experienced the electronic bullying. So maybe, I don't know, gonna age myself, like, you know, they're sending messages to each other, they're sending mean TikToks, whatever, that kind of stuff, and it's bullying the individuals. 57% were sexually harassed, unwanted touching, sexual remarks in school. I mean, that's pretty astounding. It's more than half. Again, harassment, and they're not reporting it. So they think that nothing's going to happen, so they don't report it. And then 60%, this is very important, are reporting in school and the school did nothing about it. So if let's say these clients are coming from schools to us, maybe in an agency, and nobody does anything about it, if we're just a safe place for that person to say their pronouns, to tell us who they're attracted to, that is such a good place to start. And obviously the rest of the competencies we're going to talk about is helpful. We talked about PDA, 30% are having being reported because of PDA. They're getting in trouble for wearing clothes that are deemed appropriate based on their legal sex. For example, a young child is identified as a male and that individual wears a skirt to school. They're getting in trouble. That's what this is talking about. Students are getting in trouble for discussing or writing about LGBTQ subjects. They're not allowed to go to dances with whom they want. They are being held back from creating a gay-straight alliance is what the GSA means. And it all kind of continues. Lots of kids are avoiding sports because they don't feel comfortable, and they're getting in trouble just for identifying as LGBTQ. So it's happening in schools, so again, it's happening elsewhere. This is an older model of sexual identity, Cass's model, and I always like to include this just because it shows that our clients are somewhere along in here. So the conscious awareness means you realize that that being gay is a thing. You could identify as something other than straight. And then this identity comparison, you start to commit to the identity. You're thinking a little bit more about it. You're partially accepting this identity. And then the tolerance is when you seek out those who are like you and you're trying to learn more about it, become more aware. And then you accept it. It's kind of normal. Okay, I'm a gay person, I get it. And then the sense of pride comes along where maybe you do some sort of activism or you get more involved. And then the identity synthesis. So I always like to tell students, like, this is where you can identify as a gay professor and go to the Pride Parade and have your children and they know you're gay too. You know, like it's all the things together. But our clients are somewhere along in this, and this sort of always has helped me see where they're at. So that's why I always kind of include that. Okay, so then for gender issues, there is a regular transgender discrimination survey. And here's some information. So 10% of individuals have had violence in their family. They've been kicked out of their home. 54% have been verbally harassed. Again, more than half, I think, is so important to note. Physically attacked, sexually assaulted in schools, and many are leaving school as a result. So an issue for our young people for sure. And then in adults, 30% are, I'm sorry, is that a question? No, okay. They had a job or they were fired, they didn't get a promotion, they're having some sort of other inequity because of their gender. There's verbal harassment, sexual assaults. This stat is always important to me. 29% are living in poverty compared to 12% in the rest of the US population. So more than double. And a 15% unemployment rate, 3 times higher than the unemployment rate in the US when this was created. If we did it right now, it'd be different, right? And then psychological distress for sure, attempted suicide in 40% of these people, 33% don't want to go to a healthcare provider because of worry that they'll be harassed. And I always like to highlight that because if they're afraid to go to the doctor, they're probably afraid to come to a counselor, right? And so again, this is where our education is important. 23% are not going to a healthcare provider because they're afraid they'll be mistreated. So again, development is important, and this is transgender identity development. So it's very similar to what we discussed with Cass's model, which is that we first, an individual will understand gender as an identity, and then will start to relate to the community. Maybe they'll seek out a support group of people who are like them, and then they will proclaim their identity, maybe to their friends, their parents, their families, and there's a consequence, and they're ready for that, if a consequence should come, positive or negative, I guess. And then their positive self-concept allows the person to have their identity as a piece of them, and with a partner. And then this entering the community, positive self-concept allows them to be involved in kind of all aspects. So you can see how it mirrors Cass's model. Okay, JJ.
So just as breaking down some forms of affectional orientations and gender identities, we can start with asexuality, which again, as we discussed a little bit earlier, it involves dimensions to sexuality and attraction that are underreported and not as documented in literature when we consider the bigger forms of affectional orientation that we seem to know, which is straight, gay, lesbian, or bisexual. And asexuality extends upon that, again, extend upon that conversation that we typically understand to be just the 4 big forms of affectional orientation. That is not it. You know, other people identify with varying forms of affectional orientation. We have to be cognizant of that as well. So again, the subpoint, in order to understand the sexual orientations, we need to separate the capacity for romantic attraction, sexual attraction, and sex drive from each other, as well as the circumstances under which they all occur. We have a romantic, a person who experiences little or no romantic attraction to others, and libido existing separately from these identities. That is, some ace people have sex drive. So there's a conglomerate, there is a nuanced meshing of of affectional orientation and gender identities outside of libido. So we have to be considerate of those implications as well. Now we're going to look at some LGBTQ plus intersections with other identities. Now, obviously, we can't potentially cover all the intersections, but we'll just cover just a few salient ones that we know impact practice, clinical practice. So disability is a first one. And again, when we talk about people with disabilities, we rarely, and I think it's so underreported as far as the implications for someone who identifies as a sexual minority and being a person who is disabled. And as we can see from the literature, individuals with non-majority affectional orientations were seen as having a mental disorder up until the late 1970s, which is still relatively recent. And given the impact of stigma, we can also see just the stigma alone for people with disabilities who are not sexual minorities is further exacerbated when you add disability into their lived experiences, and they also are a sexual minority. And so again, considering the overlap of affectional gender minority status and disability as relating to a singular but complete impacted part of an intersected identity. And again, to remedy, I guess, how we converse about people with disabilities who are also LGBTQ+, we need to have access to sex education that, because again, people with disabilities, let's say, for instance, a person is unable to walk. We may have sex education that is privileged, that's just tailored towards those who can walk and who can, like, let's say, meet their partners, or, you know, sex may look a little bit differently. So we need to have sex education that is, again, mindful of the intersections of disability just as a start. And again, considering guardianship laws and decision-making powers can be used to end or punish LGBTQ+ relationships. So being aware of the socio-political climate as well. HIV/AIDS, so this brings into discussion an allied field, which again, there's a lot of literature concerning HIV and AIDS, and typically it's in silos. As far as a person who's living with HIV, we do understand that there's been a heavy association with people living with HIV as far as the stigma attached to gay and bisexual men, predominantly of color. And so that is a very reiterated rhetoric that we see a lot in literature, but we have to understand that HIV and AIDS is a risk for everyone, not just individuals who identify as a sexual minority. But again, stigma is rampant, and stigma often is embedded in varying social systems, and it will definitely impact the retention of sexual minorities, the uptake of sexual minorities, and how we engender relationships with sexual minorities. So again, some of the stats that we see, gay and bisexual men are 55% of people living with HIV in the US. Approximately 1 in 5 transgender women has HIV. And epidemiology and demographics of HIV and AIDS has definitely shifted over the last 30 years. And now it's inclusive, as we said, with biomedical research and prevention methods. We understand that HIV AIDS is a global epidemic that doesn't specifically target one particular sexual minority, but being aware that the impact of the stigma around HIV and AIDS can definitely impact the way a person perceives themselves and their coping mechanisms as well. And a question that towards the end was, I guess we could just chat as we go on, why does stigma exist? So feel free to comment as we go along, and we'll pull out some of your comments and feedbacks about why does stigma exist? Okay, geography. So where a person is in relation to affection, orientation, and gender identity. So a rural person who may identify as a sexual minority may not have the same access to care as a person who is in an urban place. And a person that is in a rural area may have more community, which can be positive, and it could be a risk factor and a protective factor. A protective factor because you have community, you know people, it's much close knit, but a potential risk factor is because it's such close knit. The implications for a person who identifies as a sexual minority within a rural area, that means people may know quicker, whereas a person who's in an urban area, it may not be geographically, it may not be much of an implication as far as geography, as far as who knows, because it's an urban area, it's a bigger area. So we have to be mindful of that as well. Rural students experience heightened victimization, again, related to sexual orientation and gender identity. Again, less community visibility. And rural sexual minorities significantly less likely to have any LGBTQ plus related resources or report. Again, to continue on about geography, LGBTQ plus related mental health and other resources and services are often scarce and non-existent. Again, the idea of rural America has largely been documented to not necessarily lack, but in comparison to much more larger areas, are not afforded the same resources, funding, access to sexual health education, and it is a vast difference from urban areas as far as like service delivery and who they can contact. Let's say a counselor, there's only 2 counselors like in a rural area for like miles. And one is not as affirming as the other. So do they choose the lesser of 2 evils, or do they just not go? So those are some implications as well. And then if they shift to an urban area, it may be a little bit different. So being mindful of that as well. And if practitioner agencies and schools are competent with LGBTQ plus issues, how will potential students and clients know? And again, this is going back to what Dr. Dalton said in the beginning, beyond the rainbow flag. So we see a safe space sticker, we think, okay, this person is, affirming. But again, even though we see these stickers and see the paraphernalia for it's like endorsing that we are affirming, you have to ensure that it's a daily introspective and reflective process, that you minimize your biases and how you may feel as far as a person who may come into your practice. So these are things to be mindful of. And while some take steps to include LGBTQ plus persons in practice and advertise this, many in rural areas may be fearful to do so. I wanted to take a look at the comments as far as what we talked about. Dr. Ford said stigma exists because many folks don't know what HIV is, how it affects the body, have misinformation, and don't know the strides we made in treatment. Again, stigma, that's again an instance of stigma outdoing science and outdoing evidence-based research and evidence-based interventions and practices. And we have to be mindful of that. People of African descent tend to have more negative views towards different identities, often related to fear of rejection from their racial group. And it makes it difficult for individuals to accept themselves, particularly within family and community, and are often forced to live a double life. Have their intimacy needs met on the down low, which is a commonly vocalized term for men of color who do not identify as gay, but secretly have same-sex relations, and do not reveal them to female partners or others. And on the spectrum, historically, those who identified as Black or African American, and you introduce a conversation of sexuality and affectional orientation and gender identity, the conversation largely reflects an identity that is marginalized on the basis of race, marginalized on the basis of gender identity and sexual orientation, which also goes into a deeper conversation about what it means to be, let's just say, for instance, pulling out an affectional orientation and gender identity, to be a cis Black male within a Black family. So there are racial implications as well, there's gendered implications as well, and there's affectional orientation implications as well. So, and again, these are in silos. So race as a whole impacts sexuality and affectional orientation and gender identity. People of Latinx descent, and again, the X substitutes because some people may not identify as what we know to be Latino or Latino. Again, it's a binary form of male or female. So Latinx takes into account that people identify outside of the O, so our commonly held binary. So this is just Latinx for the Hispanic and Latinx population. So machismo is a connotation of manliness, strength, and virility, and the family caretaker. So definitely within this culture, there is an ascribing of those who identify as male, those who are cis male, or just the man in general, from a binary lens, is the caretaker, is the breadwinner, and is very traditional as far as family dynamics are concerned. So again, if we introduce the fact that someone may not identify as a man or anything that veers off from what is considered to be machismo and manliness, it's going to result in a negative view as far as the LGBTQ plus identity. It's not saying that it's not possible to be accepting within this population, but it is negatively impacted if you come from this culture. And again, yeah, may view seeking assistance as an indicator of weakness, which is very important as well, similar to those who may identify as African American as well. And for women within Latinx descent, it requires a woman to be pure, make sacrifices for the husband's and children's benefit, not engage in premarital sex, and be a nurturing female role model for her daughters. And we have to consider from this the potential inconsistency with LGBTQ plus identities. Yeah, so here's a big one, religion and spirituality. So LGBTQ plus individuals may be at risk of having negative experiences with religion because of many mainstream religions' non-LGBT affirming stances. Negative religion experiences can lead to religious or spiritual struggles and loss of religion or spiritual identity to maintain sexual identity. Religion, if we can think of one intersection that really dominates the literature as far as what causes some sexual minorities to really begin to create a medical mistrust, it would, not medical mistrust, but a systemic mistrust would be religion and spirituality, because that is the basis for most people, not all, for most people to start internalizing negative beliefs about themselves. And traditional religion does not take, again, LGBT affirming stance. And given that most individuals who grew up, for example, in Black families, we know that Christianity and religion is of paramount importance, and Christianity does not speak to an LGBT affirming stance. And if a person who identifies as a sexual minority is repeatedly exposed to the chronic messaging that is saying that we are not LGBT affirming, then that person may go internal. And then it may lead to adverse mental health outcomes, depression, who cannot talk to, leads to viewing the perception of those people around me who are attending church or attending various forms of religion and spirituality to not be a support system, which, again, all things equal, a lack of protective factors would result in an increase of risk factors. So practical implications. Many practitioners are not adequately prepared to work with LGBTQ plus clients, especially transgender, gender non-conforming, and other non-binary entities. And again, the biases perpetrated against these individuals during services, whether it's education, counseling, can be subtle, but also overt and aggressive. Thus, there may be a fear and stigma associated with receiving services. Other services can be harmful. Now, viewing it on its face is not to say that clinicians are not willing. Willingness is different from adequate training. So if a person is seeking to be trained and seeking to stay informed, that is different from a person who is not willing to work with clients. Because if you're not willing, then you're definitely going to show that and illustrate that within the counseling relationship through your nonverbals, bodily cues, and the effort that you take to be a part of that person's journey with that all this in mind.
And I just want to jump in here and say that, just identifying as a member of the LGBTQ community is not enough, right? So we need to have this understanding of identities and intersectionality, which we just covered. And then you have to have some of this knowledge that we're going to talk about moving forward. But if there is minority status on multiple levels, some of you might know about Myers minority stress theory. If you identify as a racial minority and a affectional orientation as a minority and your gender as a minority, that all can pile up to be extra stress and extra potentially harmful mental health concerns. We obviously, understand that affectional orientation and gender identity, as well as other cultural management issues, affects perceptions of every single day for individuals. So again, just knowing that there are many identities happening with our clients. We need to communicate to our clients our acceptance of diversity, including affectional orientation and gender, which I think probably seems common sense to many of us, but I have so many clients who will come and say, I want to talk about the person that I like, and they're very timid to say that. And so us just coming out and saying we are open to talking about affectional orientation is very helpful to our clients. We want to advertise in whatever way we're able to on our website that we are affirming, or maybe your Psychology Today profile that you're affirming. And if you have access to being in any sort of LGBTQ publication, that can be very helpful as well. Make sure that if you have control over your waiting room, that maybe you have some LGBTQ community information, maybe you have a magazine out, stuff that just automatically shows that you are an affirming counselor. We want to educate everyone around us. So whether we're a supervisor or a coworker, we want to educate the best we can. So if you take some information from this presentation and you share it with some of your coworkers, that will help advocate on behalf of the LGBTQ community. We must be willing to fight heteronormativity, cisgenderism, and any other sort of issues that come up from understanding only a binary world. We have to be willing to step out and say, this isn't how it is for everybody, and hopefully help in our agencies. I kind of recommend like a walkthrough of your agency or your school. So if you were a new client coming into the agency, would they see issues in your intake paperwork or your assessments? Would it say something like male or female, check one? Obviously, we're talking about not everyone falls in one or the other. So does it ask about affectional orientation, or does it just assume that you're a straight person? Sexual orientation is obviously commonly used, but according to the ACA competencies, affectional orientation is also the way we should be doing it now. So probably it'd be a pretty nuanced person to know the difference, but I think if you can start using affectional orientation, that would be helpful. We never want to assume pronouns. We talked about that earlier. And simply just ask, what are your pronouns? Not what do you prefer? What are you using today? Nothing like that. That's offensive. So just what are your pronouns is fine. Don't make any sort of assumptions about who somebody's attracted to, who they date, who they have sex with, how they engage in sex. Obviously all different issues, but we don't want to assume any of that. If these questions are relevant, then go ahead and ask. But if it's not relevant right in the very beginning, we don't necessarily have to press on those, because the clients will bring up their concerns if they have them. So for example, it would be super weird if you were doing an intake and you said, and how do you have sex? Unless that was actually part of the issue. They were coming for sex therapy or something like that. So let it go for a minute, and then it will probably come back up later. Counselors need to be trained in a kind way, discussing relationships, sexuality, gender identity, and understanding the impact that having these discussions might have on them. So that's obviously what we're talking about, but the more practice you have doing it, the better you'll be. What is in your policy? So look at your policies at your university, at your agencies, wherever you work. Does it include affectional orientation? Our clients, do they feel open to coming and talking to you? So for example, as an employee, they might be looking at your non-discrimination policy. And if it doesn't say affectional orientation, it doesn't say gender inclusive, people aren't going to want to work there. And it's the same with your agency. So try to have something out there on your website, because clients are Googling that before they come to see you. Are your terms up to date? So again, affectional orientation, sexual orientation, pronouns versus preferred pronouns. Is your hiring policy inclusive? Let's see here. How is the information out there? So if a LGBTQ person was to come to your school or your agency, how would we know it was safe? And I know Dr. Ford has said there is no safe place. Like, I could be the most inclusive therapist ever, but I might say something accidentally that could harm somebody, right? So, or someone around me could do that. So we're looking for the safest possible kind of situation. But we want to put something out there that shows that we are educated on this topic. Safe zone signs can be helpful, but you actually have to be a safe person. So don't just do the craft project and put the rainbow up there. I went to a group, a rural group. I gave a presentation. People were rolling their eyes. They were very confused. They really didn't understand what I was saying. And then afterwards, they did a project where they dumped some sand into a container and it made a rainbow, and they all put it on their desk. And I was just very concerned about what that was doing to the young people at their school. So make sure you actually feel competent enough to put up the safe zone, is what I'm saying. Do you have your LGBTQ publications out? Is it visible? Does it make people feel comfortable? What would they see on your website, for example? On my website or Psychology Today, all I have to put is LGBTQ inclusive or sex positive. And I've had so many clients say that that's why they came to talk to me. So something like that is helpful. Here's some do's and some don'ts, like we promised. You have to be aware of your own misbeliefs. We all have stereotypes in our head. We all have assumptions. We can make mistakes. We could misgender somebody. And it doesn't have to be intentional, obviously, but we need to be aware of it. We cannot expect people to be out. That is not the goal of therapy. I know that you know that, but they might be coming and we're the only person they can talk to about this concern of theirs. So we're not pushing people to be out. Don't forget that there are minority individuals within the LGBTQ community. And so we've kind of talked about some of these, but some not exactly. Often bisexual individuals feel that they are stigmatized in the community. And there's the stereotype that you should pick one, be gay, be straight, you can't be in the middle. And hopefully as therapists, we understand that people can, for sure, be bisexual or many other identities. So understand that there are those issues within the LGBTQ community as well. Walk through your facility, like we said, look at your programs, look at your therapists who are in charge of maybe group therapy. Do they really know what they're talking about? Can they properly facilitate that sort of stuff? If you have the ability, train everyone, your administrators, your faculties, your secretaries, the receptionist, your HR person, right? So if somebody is coming and HR says, oh, you're a woman, who's your husband? I see you're married. You know, that just creates such a non-welcoming environment. So make sure you can train everyone. And I want to give you all time for questions. So we're gonna move right through here. Don't neglect family members. Family is super important part of everything we're doing. Obviously, we need to watch our language and make sure our assessments are bias-free. This is the healthcare Bill of Rights. I always just like to include it. Everyone deserves to be treated equally with respect, to be affirmed, to designate who can make decisions for them, to be visited by anyone they choose in the hospital, for privacy, and to be protected and against discrimination. It's kind of adapted from the Healthcare Bill of Rights. The biggest thing here that I want to say is continue your training and your research. And one piece of that is collecting up your resources. So you want to know what's in your area, but if you are in a very rural area, you might need to have online resources. So here are some suggestions. Look for a PFLAG, a Parents and Friends of Lesbians and Gays. It's like a kind of potluck support group for families, and I found it to be very helpful to lots of families I work with. You can also look for a therapist on Psychology Today. But there are specific LGBTQ crisis hotlines. I'll leave this up for a second if you want to jot some of them down. And there are ways to find LGBTQ affirming therapists. So, for example, the National Queer and Trans Therapists of Color Network has specific therapists that would meet those needs. The GLMA, previously known as Gay and Lesbian Medical Association. So these are places you could potentially find people that you maybe feel safer contacting. And then, of course, there's no way you're going to all be able to like scramble this down, but there are so many resources starting with ACA, so you can always go there as a starting point. But there are specific resources for everything we've talked about: asexuality, bisexuality, intersex, all of the things. Lots and lots of trans resources, which I encourage you to further up.
In and of itself can be very overwhelming. And so in instances like this, you may recommend.
There we go. And some other resources. So I would encourage you to do some work to find these like across the country online resources. So if you have a client come and you feel like, ooh, this just isn't my total area of expertise.
Of course, you know, we're talking about.
Can you mute yourself?
Or you've recommended them for something.
You can
so
have
there's something beneath them.
Things available to you.
It's not just cut and dry as introverts, they're shy. There's something there, and this again is that projected
Okay, so let's evaluate. You want to just think about terms that are being supportive of your clients. Are you doing well? Who else in your agency?
And what we must do is support autonomy and pace. So again, the obvious thing to do as therapists is not necessarily the right answer.
And have you ever asked your clients what they think specifically of your office, right? Because that's the best way to know. Have you ever asked a student? So these are kind of just ways to evaluate how you're doing. And then we have tons and tons of resources. So while you guys are asking questions, maybe I'll leave some of these up and if you feel like jotting them down, you can. Does anyone have any sort of questions? Oh, yes, a copy of the presentation. Yeah, I think we could probably do that. If I don't know, I ask. Yes, exactly. There's no reason to be guessing or to be stressed out. And if you ever make the mistake of, you say something and then you reflect later at night, or as my wife says, I counsel in my sleep. So that's usually where I have problems, is at night. I'm like thinking about things. If you mess it up, you can follow back up with them. You can follow up with your clients the next time and say, yeah, you know what, I've just really been thinking about it and I messed that up, or I misgendered. Let's talk about it. And that's okay too. I don't think I missed anything else. Does anyone else have anything? Or JJ, you want to jump in here at the end? Hold on a second, you're muted.
Yeah, I didn't have anything else to add. Just wanted to say that I put our emails in the chat box if you all have any further questions outside of this topic, or if you need more information or wanted a copy of the presentation. And thank everyone for attending and coming. Thank you, thank you, thank you, thank you, thank you.
This is so much information and we wanted to kind of move through it. It's a lot, but if you feel like you just gathered something, we would be so grateful that you've learned something. And do your research to have these resources for your clients so you just have somewhere to refer them. And there's no reason to feel so overwhelmed if you see a client that maybe has an identity that's different than your own. There's lots of resources out there, so. Anything else? All right, well, thank you all so much. Enjoy the rest of the conference. There's so many good presentations. I'm excited to go to them. Thanks all for being here.
Thank you, everyone. Take care.
Oh, thanks.